So good afternoon. We're going to introduce you to some interesting biomedical issues. I think healthcare is a very important topic in Canada. A lot of people are getting older, and the population, the baby boomers, and so I will introduce my panelists. So you have beside me Geoff Fernie, he's from Toronto, and then we have Mike Carter, also from Toronto, and Tim Zakutney from Ottawa. So we're two from Ottawa and two from Toronto. We thought we'd give you a balanced panel. So, so my particular interest is in perinatal care. So from the time that a baby is in the womb until delivery, and then some of them end up in the intensive care, especially if they're preterm babies. And then, of course, the young years. So I work a lot with the Children's Hospital of Eastern Ontario, as you can see down there. What I do is I predict outcomes using machine learning and other data mining techniques. And I'm very lucky that with my 20 years of experience in hospitals, I developed a credibility with physicians, and they have entrusted me with very high-quality databases that I can use for training my systems so that we can eventually give those decision aids back to the doctors and the nurses so that they can manage the patients better, quicker, and also manage resources. So that's part of the policy is, you know, there are only so many ventilators, only so many nurses. So if we can predict, you know, how many days the baby is going to be on a ventilator, then they can better plan the admissions and all that. So, so I predict length of stay, which is also a big impact on nursing care. Usually with those babies, it's one-on-one, but it can be sometimes, if they're not as sick, maybe 2 babies per nurse, but when they're very sick, it's one-on-one. And we also predict several complications, and we're now getting data in real time so that we can actually predict before things happen, hopefully. And of course, we want to predict things that can be acted on. It's okay to predict things in general way, but you also want to predict things that the doctors can do something about. And then I'm going to tell you a little bit about PPADS. That's the Physician Parent Support System. And also we're imaging the abdomen because 30% of premature babies get necrotizing enterocolitis. No, those who get necrotizing enterocolitis die. So 30% of those patients would die. So it's very important if we can get it early, this disease, then we can prevent. What it is, it's an inflammation of the bowel, and eventually there's necrotizing, death of the tissues, and as I said, a third of the babies die. So what they do is when they think there's going to be a neck case, they give some very harsh therapy. So if we can tell in advance, predict the babies that will develop neck, well then they would be in a better position to manage this disease. And in obstetrics, we have now a system that is the highest performance in the world on predicting preterm birth. We use only data collected in the physician's office by week 23. And we are now equivalent in performance to a very invasive test that's very expensive called fibronectin. And that's done only by week 28, which a lot of babies, you know, can be born by week 24. So we thought just using data in our predicting tools, by week 23, we can tell with quite high accuracy if this baby will be preterm or not. And most of the literature will tell you that for low-risk population, the performance is 15% of predictability, and we are predicting, at the moment, it's 85% compared to 15. So this is our physician partner, Dr. Bariziak. She's a neonatologist, a really excellent one. If I had, not at the age of having babies anymore, but if I had a little preemie, I would like her to look after it. She's totally amazing. And she says this is work that we do with her is so important that all medicine, adult and pediatric, is going to be headed that way. So we're very lucky that we have a very enthusiastic physician to work with. So this is the population we're looking at. Some of them, I just saw one a week ago, just weighing about 700 grams. I mean, they're so tiny, lots of machines around them, and very good care. So the problem is actually quite increasing. Preterm birth is now the leading cause of infant mortality in North America, and the incidence has increased 20% in the last few years. And a preterm birth also leads to significant morbidity, which are major complications and life-altering changes, like being quite disabled and things like that. So these are some of the complications we're looking at. Heavy bleeding in the brain, right? Because that causes sometimes the baby to grow up and not have any functions and being a very low quality of life. Then pulmonary problems and all that. So the physicians need more accurate ways to predict these outcomes so that they can prevent if they can, if it's, as I said, actionable. And they can initiate sometimes timely treatment and guide resource allocation as well, like I said at the beginning. So monitoring systems, babies have all these things monitored, their heart rate, respiration, oxygen saturation. They get blood tests so that they can see the blood gases, the oxygen, carbon dioxide in their blood. And the blood pressure can be non-invasive or invasive. Temperature as well, and coming soon, they already have the modules at the children's, but they will do the brain activity as well for those who are in danger of having brain damage. And the potential future applications, I also have my other big section of research is infrared imaging on rheumatoid arthritis, piano playing related injuries or potential muscular development of muscular problems. And so we actually going to do this now for the abdomen of the babies so we can predict, use the features from those images into our decision support system so that we can predict neck more accurately. So then we capture now in real time. We have millions and millions of points of data because we've been collecting this for a year and a half in real time at the children's. And we correlate this, of course, with lab, radiology, all other tests, so that we can develop this real-time prediction tool. So this is what it looks like. I'm just going to go very quickly that my student, Geoff, who's a PhD, is on this project, has done an incredible work. This one is funded by Philips Research North America in New York. And he has been able to separate right from when the data comes in HL7 and all that with mirth. He separates the identification of the patient with the data that can be used for research. So what we get in our lab is the green part. So we don't see any ID at all, which is good. But the physicians can use the ID back to look at trends and look at other things that they're interested in. So we talked about the predicting outcomes. We'll just move on. And we use different data mining techniques, decision trees, neural networks, statistics, and all that. Mortality is the most important one that the doctors want. They say they cannot perhaps do it as good as the machine because they'll say, well, I saw a patient like this, and this is what happened. But how many patients can they remember when they see little Johnny or little Susan this week? So the machine can remember, hundreds. And so, but I wouldn't want the machine to do the big decision in the end. That's got to be the doctor. And I've worked with doctors long enough to say we don't replace the doctor at all. We are just giving a decision support to the physician. And so this is the real world you're looking at. Lots of machines. There can be up to 20 machines on the tiny little Premi like this. Now, why we develop PPADs? It's because in certain cases where it is so difficult, the baby is going to have no life, the situation is very, very bad, the baby's going to die, and instead of keeping the baby on very invasive technologies and believe me, there's a lot of pain that can be associated with invasive technologies. So at times the doctors are trying to tell the parents, you know, it's time to go to palliative care so that you can hold your baby, you know, and the baby can be more comfortable and we'll look after it until it dies. But some parents, they say, throw everything at it. I refuse this way. And so we feel that if we can give more information to the parents, maybe they can make better decisions more timely for their infant with the physicians. So we had ethical clearance to do the first batch of parents would be the ones who had an infant who graduated from the intensive care. In other words, the baby survived and they went home. So we already did several of those parents, and the second step will be those who lost an infant, and that will be phase 2. And the last phase will be to look at parents who really want to use the system, whether their infant is really, really sick or not, but intensive care, so that if they want more information, this is 24/7, they have access to. So for the clinician, we have a homepage. We show the patient files. Maybe I'll show it to you right now, but activate the patient parent account. So some parents don't want to know. They just say, okay, you doctors, you know, and you make the decisions. Other parents want to know everything. So we really will make it that it's the parents who, you know, will be activated if they really want to use this. And they don't have to see everything. If one parent out of 5 said, I don't want to see the outcome prediction, that's fine. The parent doesn't have to see that. So the doctor will activate what the parents will see. And the parents can see the current conditions, current treatments, outcome predictions if they want to, and the decision support. It tells them where are you at in the decision of, and you'll see in a minute, the 3 decisions that they need to make. And there's a glossary. You can click on any of the words. What does that mean, neck? And so there's a whole explanation, and we work as if people have grade 8 education in school. So very sick. So for example, we have a little patient now which is very, very sick. So then they could either full active care, or withdrawal of life support, or non-escalation of care. Those are 3 very big decisions that need to be made. Now the clinician homepage, you can see if it's 3 reds that going up, that baby is in real trouble. If it's green, well, it's getting better. And if it's blue, then it's pretty stable. It's staying the same, whatever it was. And that's when the physician can activate the parent modules. And if clicking on any one of those patients, the physician can retrieve files right away. Do you know how long it takes to get a file from medical records when you're looking for one? If they can find, well, usually they can find them. But so this is really the clinician file. You can see we decided, I'll show you too. Whoops. Well, the other way. Okay, so see those we decided, we used to give them a number, 86% mortality. Well, we didn't like that, and the doctor didn't like that. So finally I thought one day, well, let's do like a speedometer. And if the infant moves from the green to the yellow to the red, then you can see the infant right away on an image that it's getting worse, it's getting better. So the doctors really like this. And now just go a little bit on preterm birth. So this is a very complicated problem, and most people in the literature can only predict high-risk populations, but we are now able to screen the entire population, and as I said, with 85% specificity, which is the cases that will not be preterm, and with 66% sensitivity, which is the cases that are thought to be a preterm birth. And this was done by Nicole, one of my other students. And so if you can see, we developed, we had a big, huge database, millions of cases with 300 variables from the CDC Center in Atlanta. It took us several years. Believe me, it's very tough contracts and many years of negotiation to get data like this. But it has led to some wonderful results. So paras are women who had a baby before, and nulliparous is women who are having their first baby. And we divided those two populations, then we trained and tested our neural networks, and you'll see that, whoops, I guess I just have to tell you like this. So we had really good results with the paras, because some of the very important variables were having had a preterm birth before. And of course, with nulliparous, we don't have that data. So just to tell you that overall, we are now just very close to testing in the real neonatal intensive care, the physician module. The parent module is being tested now with parents. And now next year we've got to do some programming. Our Phillips grant is for 1 more year to do the prototype that will merge the two, that will merge the outcomes for physicians and the parent modules together. So we're very happy that things are going to probably change a lot the way that things happen in those areas, and help both the parents and the parents and the physicians. So that's it for me, and I think that now I will pass this over to Mike, who's going to, whoops, I guess you just have to turn it off. Okay, well, thank you very much. So we'll hold your questions till the end, I guess, because we're a panel, and after my other speakers here, then we'll entertain questions. Thank you.
Thank you. So Mike Carter, I'm from Toronto. Don't hold it against me. It's not my fault. I didn't elect the mayor. I just picked up from Leslie's talk earlier, and Leslie, one of the comments she made was that engineers make things run. Well, nobody ever engineered the healthcare system, and it really needs it badly. And that's sort of my message, is that I'm from the industrial engineering, systems engineering side, and it came up, the healthcare system evolved 100 years ago from the family doc who was doing surgery in the back room, and we're still using the same model. It's still a cottage industry, and it's got to change. So a lot of the stuff we do in the Center for Research in Healthcare Engineering, we have about 20 students, 5 professors, and 5 full-time staff. And we're looking at how to see if we can make the healthcare system run a little better from an efficiency perspective. And so I've been doing this for about 20 years. And what I'm going to do, because this is a policy group, so we're doing a lot of operational things too, but I'm going to talk about some of the policy aspects that we've been... There we got it. Okay. And I'm just to show you a few things quickly that I'm going to talk about 2 specific ones, but just to give, we're doing a lot of work with Cancer Care Ontario. So thoracic surgery centers in Ontario, there used to be way too many hospitals that were doing thoracic surgery. There was a link between volume and quality. A lot of centers were only doing 20 a year. And so Cancer Care Ontario asked us, if we had centers and reduced it to the following places, what would the catchment look like? So who would go there and how many would they have? So we built a model to help them. Radiation therapy wait lists are a big problem. I'm going to talk a little bit about some systemic therapy, HHR, and resource implications of integrated cancer screening. Most of you, at least ones over 50, know about colorectal cancer screening and things that are coming up. What are the resource implications that are going to happen with colonoscopies and things like that? And utilization and allocation of PET scanners in the province. Some of the other things that we're looking at in more generally, so reduction of Ontario surgical wait lists. So about 5 years ago, we had a project. Minister Smitherman came to us and said, how many hips, how many knees, how many cataracts do we have to do so that 90% of people will get their surgery in 6 months? And that's not a difficult question if you actually knew how many people are on the wait list, and they didn't. So we actually recreated the wait list, never mind. Supply and demand for aging at home services, I'm going to talk a little bit about that. One of the people at Ministry of Health asked me, I'd like a model of the healthcare system, and we're building one, never mind. Next year we'll talk about that. And then looking at influenza pandemic planning, the H1N1 we had, what were the logistics behind that? Nobody really thought about how you were going to actually deliver all of these antivirals. Hospital bed capacity planning, cause and effect models for mental health that we've been working on. At any rate, so I'm going to pick on two of them. And one of them is for the aging at home strategy. The aging at home strategy, as most of you may have heard, so $1.1 billion were dedicated by the Ministry of Health and over the last 3 years. And the idea was to try to help seniors get care at home. This is a simplistic overview. So they're trying to reduce stress on institutional care. Province was worried about alternate level of care, people blocking beds in hospitals, people long waits in emergency departments. How can we get things moving? Well, if we can keep people at home, we can, hopefully improve the situation. But the problem was how to allocate funds. So the ministry just gave it to the regions, the 14 LHINs, the 14 health regions in the province, and said, go forth and keep people at home somehow. And so the LHINs, and initially the Central East LHIN, came to us and said, where should we be allocating? What services should we be putting money into so that we can somehow facilitate people staying at home? And so this is a supply and demand problem. And so I'm not going to go through this in detail, but this basically says that what's the demand for home care services? And the services we were looking at were things like services like assisted living, adult day programs, transportation, respite care, things like that. So some of the services, and so the demand. Now, the first one, we actually went to the service providers and asked, what is the population that you provide for? And the second thing we did was we went to the census long form. Don't get me started. This is your fault. You're in Ottawa. Okay. So we went to the census long form to find out what services people actually need, something called the PALS survey on that Census Canada used to do, and get information about what people actually needed. The third thing we did, we brought those together and applied them to local census population to try to get a sense of what is the demand in the population. So here's the Toronto Central LHIN, for example. So here's the demand for adult day programs that we picked up using the long form to figure out what the population is at census subdistrict level in the population in the City of Toronto. We then got on the phone and called up all suppliers and asked what their catchment area is. We know there's a place in Peterborough that does Meals and Wheels, but we don't know how far out they go down to Peterborough. So we actually had to call them up. So we created a supply model for adult day programs within the City of Toronto, where they're all coming from. We put the two of them together, and we created a gap model. And the red zones are where there's lots of demand and no supply, and the blue zones is there's lots of supply and no demand. We initially did this at the Central East LHIN. Central East LHIN goes from highly dense Scarborough up to Haliburton, so it has quite a bit of population. We showed this to the other LHINs, and then we spent the next year doing it for all 14 LHINs to try to figure out where their demand was. One of the interesting things was we weren't really telling them how to allocate funds, but the LHINs were going to suppliers and saying, we will give you money to do set up something in your LHIN in this area. And the LHINs, the Central East LHIN, said they really found this useful because it gave them quantitative support for things that they knew intuitively. But when they go to the suppliers, rather than just saying that, it sounded like they were making it up. Anyway, so this is very helpful, all 14 LHINs. The second one I'm going to talk about a little bit is the models of care. It's an ongoing project that's going on right now with Cancer Care Ontario. The problem is that cancer is growing, and more so, not only is cancer growing, but because cancer treatment is getting a lot better, people are living longer. So what's happening is that the population of people who are living with cancer is growing, as well as the population going up, as well as cancer going up. And so there's a major health human resource problem. Do we have enough people to look after the population? And can we make better use of the population that we have? So the issue we're looking at is, in Cancer Care Ontario has a major 2-year project, pile of people involved, we're supplying decision support for them. What's the best team that you need? So for example, medical oncologists in systemic therapy are doing work that could be done by a nurse practitioner. Registered nurses, RNs, are doing work that a clerk could do. But it actually depends, so do you have enough of the right mix of people at each one of the cancer centers, and it depends on the size of the center. It depends on the population you're getting. So, for example, at a very high level, we went through and we looked at, as you go through, this is for systemic, for chemotherapy, looking at each one of the operations, who's involved in each one of the steps. And we went around to about 4 different centers and started interviewing people and shadowing people to find out exactly what they did. This is a bit of an eye test, sorry about that. I can send you detail. But this goes through and says, so for each one of, the first one, for example, is a consult. And at a consult, what are the tasks that happen? And for each one of these tasks, any industrials in the audience? For each one of the tasks you do, then who does it, how many people do it, and what we were concentrating on is we were concentrating on tasks that were done by multiple people. So then we take all this together and put it in a little mathematical programming model, and we come up with a model that can answer the following kinds of questions. So one of the questions, it says, so given a current population of patients, what's the right mix of providers? How many providers do you need at your center, at going each one of the cancer centers across the province? Given a current set of providers, how many patients can you treat? What's the population you need to look at? We can look at how many providers are needed under different models of care. So if you change who's providing and who's giving out the care, then how many people can you look at? And we're also looking at, further down the road, looking at benchmarking, looking at how, this is what the model says you can do, this is what you're actually doing. These guys over there are doing it differently, and they're getting more patients through. Maybe you should have a look at what they're doing over there. We're currently in validation. It's tricky. Turns out we actually don't know how many people are providing care at any level in the province, which makes it kind of exciting. Anyway, this is just a screenshot of the model, and all it does, the interface, is just, given a volume of patients, given the distribution of what the patients are doing as they come through, relative weights for each one of the types of people who are working, how many minutes a week they're working, the model comes through and tells you how many people you need, so you can play with those. And lastly, some of the things, the models that were being considered, some of the things that CCO is considering are things like follow-up care. The doctors are doing follow-up care for people. These are healthy people that have all been treated. So in fact, nurse practitioners could probably do that and then flag the ones where there's a problem. Nurses actually often give better care than the doctors. They spend more time with them. Improve how patients get into the system. So we're looking at systems like central intake and by a nurse practitioner and screening. Right now, if you get sent for cancer, if you get sent to a surgical oncologist, they will probably recommend surgery. Okay? If you get sent to a nurse practitioner, they'll figure out who's the best doctor to see. So there's a number of different things, enhancing technology. And one of the big things that's coming up is cancer treatment for palliative care. Palliative care is pain management. You can treat pain management by radiation therapy, by chemotherapy, and by surgery in some cases. Our palliative patients are not getting cancer treatment. Why? Because we're stretched for demand, et cetera, already. So those are some of the things we're looking at, and thank you very much. Thanks, Monique.
So next is Geoff Fernie.
So mine's pretty simple work. I'm quite a simple guy. And I'm going to ask you what you think growing old successfully means. And to me, it means 3 things. It means I want to continue to live in my own home. I don't want to, having gone through all my life, build a family around me and neighbors and things and all my hobbies and stuff. I don't want to exchange my home for a 200 square foot nursing home room with 1 cupboard. I have no interest in doing that unless I have to. I want to stay safe and active. I enjoy active things. I want to stay doing them. I bet you do too. But also I want to be able to care for my family, because we do care for each other, and that's quite important, because during your lifespan and my lifespan, we have about a 1 in 2 chance of having a significant disability ourselves. And if you put that together with the chance of your family having a disability, it's almost certain that what I'm talking about is very relevant to your life. There's a very nice professor, dear old lady in Britain, Anthea Tinker, who organized a research project where they went into people's homes. I'm now talking about the first question. I'd like to continue living in my home. And they asked them, what are you worried about? Well, you might think that they said their health. In fact, they said the stairs. And when you think about that, that's fairly obvious, because people worry about whether they're going to be able to manage their stairs, whether they should be exchanging their house for a bungalow or moving into an apartment or something. It's a big deal. And yet we're building places like this. This is in Toronto. We're building all over the place row townhouses with ridiculous entrances and ridiculous flights of stairs within them, which are obvious death traps, and you're obviously not going to be able to get up and down them. We've studied for many years balance. We tend to use moving rooms, and we study balance itself, but also the interaction between rescuing yourself from a fall and the environment, for example. And in more recent years, this has now found, when we're talking about policy, we've now got a situation where engineers are running clinics. We have clinics at Toronto Rehab which are now spreading out into other hospitals and other centres, where the therapists bring their patients and the researchers apply the technology, and between them they work out the best therapy for the patient. We do this on every single stroke patient. We're about to do it on every head injury, and we're about to do it on every geriatric patient. The lady you see there is being held by an electromagnet, and she's being told to lean forward. It's simple sort of technology. She's standing on force plates, the magnet lets go, and then she has to recover her balance. And we're able to learn a great deal that's useful for her therapy. We also develop products. This is one that you can buy for $29.99 at a lot of pharmacies. It's an insole that goes in your shoes, and interestingly enough, we've been finding that it's as much as cutting falls in half. We don't have enough numbers yet to really say that definitively. We can say in the clinic we're able in the laboratory to demonstrate your balance is improved on rough ground, and there's now a huge study starting in Australia to actually definitively show the number of fall reductions. Mobility, sometimes you need a wheelchair or something, and I just showed this as another product because it's one you'll have seen. It's one of ours called Staxi. You'll have met it in a lot of hospitals. I'm now meeting at a lot of airports. We're supplying airports all over the place because as a senior, you don't necessarily have to use a wheelchair all the time. But when you get into a place where you've got some big distances and some luggage, then it's really, really important to be able to be transported. And without a lot of arranging for special volunteers and special access to special services, you just put a coin in the slot and take one. It's a surprise to me that no researchers have, or very few researchers have ever paid much attention to winter, especially since it happens in Ottawa for something like 10 months of the year. And when you talk to older people, they're actually stuck inside for very many months of the year, often because they're frightened of falling over, but it can be really difficult to get around. And this is another area where engineers can play a big role. For example, we have a climate lab, and there you see one of my PhD students walking on a mixture concrete pathway with some icy patches, and there's a little slope there, and there are force plates underneath each of these patches so that we can analyze how you walk over the surface and, for example, detect with 3D motion the moment you slip and calculate the coefficient of friction that's available at that moment in time. So you can imagine we're doing a lot with the footwear industry. It's the test for footwear is actually stainless steel with some oil on it. Well, that doesn't bear any relationship whatsoever to walking on ice and snow, especially if you've got some little crampon sort of things or spikes or whatever in the footwear. So we're looking at that both from the footwear and also from the environment. Can we avoid ramps? When you talk to people about whether their city is accessible, whether it's friendly for older people and people with disabilities, they say, yeah, we've got curb cuts everywhere. Shame. Because curb cuts were invented in Berkeley, California. Curb cuts in our environment look like this most of the year. Surf's up, except that surf is actually ice. They're deep puddles, and they're a ridiculous engineering solution to getting from the road to the pathway and vice versa. So this is a laboratory that we're just commissioning. This is one scene of it, where we're commissioning to explore these kinds of issues. And this is the payload bay, and I've got 3 payloads in there. If we look at the back right, there's a laboratory which is for stair testing, and we can measure every force applied to every step, and we've already influenced the building codes throughout North America, almost every province and every state for handrails, and we're now tackling this issue with stairs. And you say, well, what's that doing in a hospital? You know, in British Columbia, it's now been found that we are killing and seriously injuring 3 times as many people on stair falls as we are in motor vehicle accidents. Our number of serious stair falls is increasing across North America at 6% per year, and we've got a compound curve going on there, so this is becoming very serious. In Ontario, we have nearly 4,000 people with major, significant length hospital admissions a year as a result of stair falls. And those stair falls, it's thought, 90% of them or more are due to errors in geometry of the stair. So we're trying to understand this better. In the back left corner there, we have winter. We have a real ice floor. We can generate winds up to 50 kilometers an hour. We can generate very, very low temperatures, and we can generate snow in that space. And there's a robot that follows you over your head to make sure that you're safe. In the background over there, we have an environment for studying complexity of the world. You know that you're not supposed to use a cell phone and drive at the same time. Well, actually, when your balance gets poor, you better not walk and talk at the same time. And you'll see seniors don't. They stop talking when they're walking, and they stop walking while they talk. You'll see all sorts of other issues. For example, hearing aids are now implicated in falls. There's a lot of very interesting things to do with complex environments. This complex environment, we've actually created, or you can, the background sound can perhaps be turned down here, but we've created a 3-dimensional model of our part of Toronto in extraordinary precision. And you can encounter pedestrians and traffic. We can change traffic light, change timing and stuff. And we can wheel and walk around a virtual reality system that encompasses you with, for the first time, high-performance soundscape as well. Let's move on. So each of these laboratories can, in fact, be picked up by a 10-ton crane, and we can move them through onto a motion base, hydraulic motion base, very quiet, smooth-moving base, that we can use to sometimes just create a hill or a slope to see whether you can go up or down it with your footwear. Sometimes to simulate introducing an IV or something in a helicopter, or we're doing some stuff for aircraft soon for intensive care units in the air, or an ambulance or whatever. Sometimes just to disturb balance. There's winter at a peculiar angle. You try to walk up that, and you're in extreme. But we have to plan for extremes, of course, and there's one of the extreme tests where we slam winter at 2.5 G towards the wall, and the ice didn't come apart, fortunately. So my third point was that I want to be able to keep my family together. How do I look after my wife at home if she needs care? How does she look after me? You say, well, that may not be very relevant. Well, in fact, over a quarter of families in Ontario have provided continuous care during the last 2 years. The family is now the biggest element in the healthcare labor force. Family caregivers, working under extremely difficult circumstances, often having to give up their careers, give up their social lives, become very impoverished. I've got a whole bunch of statistics. 20% of them are in pain. Many of them need help, need care themselves. They're desperate. When you look across some of my labs, they'd look out on a window, but the window you can see is onto a balcony. And when you go out onto the balcony, you can look down into a house that we've just built on the 12th floor, and also into a hospital ward, where we're able to test out some of the various products that we develop. So the products that we develop often deal with what stresses caregivers. And there are 3 kinds of stresses. Physically demanding tasks. Imagine your mum having to look after your dad or whatever the equivalent in your family. He's coming home tomorrow. He's just got out of hospital. He's got out of hospital in 9 days. And there he is, and he needs to go to the toilet in the morning. and you've then got to get him off the toilet, cleaned up and dressed, and he doesn't have the ability to do it himself. How are you going to do it? How is your daughter or your 75-year-old mother going to do this, especially in a narrow little bathroom with no technology? The situation is desperate. You will not get community health support. I mean, you'll maybe get 2 or 3 visits a week to start with, but that'll die off, and you'll be in trouble. So how can we do this? So we do a lot of work in that area. Mentally tiring tasks. If you've got someone with dementia, and I can tell you this from personal experience, because my wife had 2 brain aneurysms. She's recovered now, but I thought I was going to be looking after someone with severe dementia for the rest of my life, that you've got to watch them every minute. You've got to help them not have an accident. You've got to prompt them through every single task. And not only that, you can't sleep at night because you've got to listen for them getting up in the middle of the night, going and falling over or leaving the house and walking out into the street or whatever. So mentally tiring tasks. And the third thing is the stress of living a second life. You want to still have a life for yourself, and that's tough. Just to give you some clue, you're all concerned, I'm sure, with accidents in your own industries. And here we're looking at professional caregivers. On the left, you see nursing home accidents, injuries per 100 workers, then hospitals, then manufacturing industry, construction and mining. Injuries to professional caregivers exceed all other activities, all other workplaces. Now, you can stretch that into the home environment and imagine what the statistics are that we don't have. So we do lots of work in this area on how to reduce them. And one of the things we've been doing is we've been developing various patient lifts and things, but we found that the patient lifts didn't solve the whole problem. And in doing mechanical analysis of how to get something under the patient to lift them, because the irony of a patient lift, like so many ironies in life, is that in order to lift someone, you've got to lift them or roll them to get something under them to lift them in the first place. We find that that's potentially injurious. So one of the inventions that has come out recently, this was an early prototype. We actually built hundreds of these, allows us to shoot lifting straps under people, and we can shoot 3 under them, lift them a little bit, and then put a sling under. But notice there's no friction here. What it was like 2 caterpillar tracks. It's like unrolling your socks. When she pulls it out, it's no effort at all. What it's doing is it's turning inside out, right, and coming out. It's called Slingserter. So it's now coming. It's about to be launched on the market with a little gun-looking like device and stuff. And in fact, I've found no limit to the weight of people I can lift. So it doesn't seem to be an issue, and we have a lot of fun. You can turn the sound up if you like. So my last comment that was the physical task of caring at home, the mental tasks. And one of my graduate students, Alex Mihailidis, has gone on to be a professor in my group, and terrific guy, and he talks about the intelligent brick. And one of the things he's developing as an example is a bathroom towel that when you stand on it, not only measures your weight, but also your blood pressure. And we're working towards intelligent materials, low-cost materials that help take that stress of continuously monitoring someone and assessing them away. One of the tools is a smoke detector. It actually has a smoke detector in it, but it also has a little camera. And it watches, and if you fall over, it knows that you've fallen over, it protects your privacy, it engages a conversation with you. So you don't have to be wearing anything. The buttons you wear, 70% of the time you're not wearing them when you fall over. And the times when you're really hurt, you can't operate them. This thing talks to you and says, do you need some help? And if you say no, it's fine. It'll let you lie there for a while. It'll ask you again eventually if you don't respond. If you don't respond, it has permission to call for help. Otherwise, it'll talk to you about who to call. This system is also now watching what you're eating, what food groups you're eating, how you're behaving, how often you go to the toilet, all sorts of things which can be helpful. Now, here's an example where it's actually, this is a bit way out, admittedly, but it's working. This is a lady with severe dementia. Have the sound up for this one when I started, and listen carefully. She's trying to wash her hands, and all of the speech will be from the computer helping her. So it recognizes her, it has actually learned how to talk to her, and how she likes to be talked to, recognizes her actions from her hand movements, and realizes that she responds quite well to a visual prompt, which now we do with iPads, just stuck on the mirror and stuff. Now, I don't think we're really going to do this with severe dementia, although it's not totally impossible, but certainly with more mild cases we will. So I'd invite you to visit us, get involved with us at any time. We'd love to see you. And in fact, we have a big conference in June, 6 international conferences together, followed by a special 7th conference on stairways. And there's an open house on the Sunday for you to visit us. Thank you.
Thank you. So our last speaker is Tim Zakutney.
Thank you, Monique. Thank you to the Ontario Centre as well. It's a real privilege to be here. My talk is going to be slightly different. Geoff, you should have gone after me. Like, that was amazing, your presentation, amazing. I work at the University of Ottawa Heart Institute here in town and affiliated with the Carleton University in the Department of Systems and Computer Engineering. This symbol here means different things to different people, particularly in this room. It's about patient safety, it's about public safety, workmanship. And when Professor Haltain of the University of Toronto first asked Rudyard Kipling to draft the Calling of the Oath, that's what he was focused on. And it's really quite, as you can imagine, extremely vital to our profession in biomedical and clinical engineering, just because as opposed to perhaps 20 years down the road, issues that arise with our function within the hospital are immediate and can easily result in patient death or severe injury. But in fact, this particular man also has a sort of role in clinical engineering. You may recognize him. He's an independent thinker, former US presidential candidate. This, of course, is Ralph Nader. He actually wrote an article in all magazines, the Women's Journal in the 1960s, suggesting that there was a prevalence of microshocks in U.S. hospitals. A microshock is less than about 1 milliamp of electric current invasively in the body and potentially can put a patient into cardiac arrest. And as a result, that was a contributing factor in the 60s to the growing presence of engineers and technical skill set in the hospital environment. And we saw a lot more electrical safety being performed and more focus in terms of the growing prevalence of medical devices in hospitals across the world. So who are biomedical and clinical engineers, and what do they do? I consider myself a clinical engineer. Biomedical engineer uses traditional engineering expertise to solve problems in biology and medicine, whereas a clinical engineer, as defined by the American College, is someone who's applying engineering and managerial techniques in the healthcare environment, so within the hospital environment, at the bedside, and with respect to technology and patient technology. And predominantly across North America, the services or the functions that clinical engineers do within the hospital environment are pretty consistent. They do healthcare technology management, capital equipment procurement, medical device management, and this actually evolved out of the initial stages of electrical safety and that piece, as Ralph Nader suggests. But there's a huge focus on patient safety and risk management. What are the risks associated with using technology, whether it's used appropriately and safely? So is patient safety a growing concern in the healthcare environment? A resounding yes. And in fact, in 2000, there was a landmark report issued to the Institute of Medicine called To Err is Human, and what it recognized in U.S. hospitals, there's about 1 million injuries per year with respect to what we would call adverse events. Almost 100,000 patient deaths per year that could have been preventable at a cost of almost $30 billion. Now, in Canada's perspective, there was a study done by Baker in 2004, which recognized there was about 7.5% of all patient admissions contained in it one or more adverse events. So that's one or more. And of those 7.5%, almost 37% of those are highly preventable. What does that mean in the grand scheme of things? As this data was extrapolated across Canada, that's almost 24,000 deaths that could have been preventable in the healthcare environment in Canada. So when we think about adverse events, we traditionally will think about maybe medication errors, and there's this cartoon. This report, this 3 clinicians or clinical staff are sitting by a bed and puzzling trying to look at this thing. This report says medical errors such as indecipherable prescriptions cause the deaths of 98 patients a year, or is that 98,000? It's hard to read this. In any case, will be supposed to report them, or is this repeat them? And you see the patient next door trying to put back his medications with no regard. But on a more serious note, in June of last year, this article showed up in the Ottawa Citizen. And this is about a BC woman who was 61 years old, ALS patient, was on a bed attached to a mechanical ventilator plugged into the wall. The clinical staff put the patient into a wheelchair on a transport ventilator that was running on a battery, moved her around a bit, returned her into the bed, but forgot to attach her to the mechanical ventilator on the wall. Went back several times just to check on her, and then the last time they went back, the patient was dead. And you can just imagine all of the circumstances when you think about this. There was an audible alarm on the device. It was intermittent. It wasn't very loud. And so the role of a clinical engineer in the hospital environment, apart from technology management and strategic planning and replacement, we would apply these 4 to 5 principles, and when we do an incident investigation, identifying what are the contributing factors in terms of the device, the operator, the facility, the environment, and the patient. And just if you go back to that circumstance, you can really see a lot of issues specifically about the device and also the application of the device. And in fact, in 2004, AMI, the Association for the Advancement of Medical Instrumentation, did a review of 80,000 adverse events that were reported to the FDA, and 1/3 of those directly involved a medical device in some instance. And so the clinical engineering research we do at the Heart Institute, we do things like medical battery management, excuse me, engineering involvement in a cardiac arrest team. So when a patient has a code blue, they go into cardiac arrest. What role does engineering play in that? The role of thoracic impedance in cardioversion success, device utilization, quality documentation, and AV integration. All of these things, and in fact, all of those sort of functions within the hospital environment directly relate to patient safety. So this is a public policy conference, so I should speak some kind of policy. And I'm being very brutal and crude with respect to when I talk about the Canadian healthcare system. I've got here provincial and federal, national, and local municipal, but in fact, really the patient is a very key component in this in this system, if you can call it that, actually. It's debatable. When we talk about a municipal and local level, there needs to be an increased involvement in clinical engineering in all healthcare organizations, and really this is varying across the country. Certain urban centers, academic hospitals have a very good presence, such as U of T and in Ottawa. However, for the most part, small hospitals, rural hospitals really have very little engineering presence in those areas. And in fact, when you consider there has to be a great deal of management and oversight with respect to technology in these areas. There has to be an increased collaboration between universities and healthcare organizations, certainly, and an elevated profile within the local, within the LIN, in terms of biomedical engineering. Clinical engineering in a LIN is a very natural group to sort of collaborate together. Technologies are primarily the same from hospital to hospital. The way they're used can be quite different. The way they're maintained and managed can be very significantly different. When we consider on a provincial level, ensuring that specialty trained clinical engineers oversee the technology aspects, And in fact, there's certification associated with the people involved in these functions. Pursuant to, after becoming a professional engineer, you can pursue becoming a certified clinical engineer or a certified biomedical engineering technologist for the technologist profession. And also involving clinical engineering and provincial-wide technology planning, such as from the OHA, and participating in those evaluations of technology and how they're applied. From a federal national level, there really needs to be a good relationship with Health Canada. And in fact, Health Canada is actually fairly good at collaborating with clinical engineering groups and reaching out. In 2004, the Auditor General did a report, well, unfortunately for them, but they did a report for Health Canada, and they really focused on a number of things, one being device licensing and trying to expedite the licensing process for new devices coming to market. The second was their capabilities and their resources and capacity to do post-market surveillance, and that's monitoring adverse events and monitoring what we would call near misses. So it's not an adverse event, but something that was caught before an injury occurred. You'd be surprised to know in the United States, because of the Safe Medical and Device Act in the United States, if an incident occurs with respect to a medical device or technology, the hospital has mandatory obligation to report that to the FDA. In Canada, that doesn't exist. It's purely voluntary. It's only the manufacturer has a mandatory obligation to report. So it's very important for that close relationship exist and that process be streamlined. All hospitals within Canada undergo an accreditation process every 3 years, and primarily it's a self-evaluation in the sense that you look and you do risk assessments. That certainly has to be more strict in terms of how hospitals are managing their technology, how are they planning for replacement, how are they maintaining them. And in the past, it's actually been very, I would say, washed out within the overall accreditation process, and it's starting to improve. In the United States, it's extremely specific, it's extremely detailed, and so we see a real prevalence of clinical engineering occurring in the United States, and so hopefully that'll improve. And there are collaborations between the Canadian Medical and Biological Engineering Society and Accreditation Canada for improving this. And also, of course, an increased collaboration between industry, the manufacturers of these technologies, and clinical engineering groups. I've been visiting different manufacturers who've asked for input, and it's very well received, and it's a breath of fresh air in terms of them understanding what our technology needs are, not just simply from a clinical perspective, but from an engineering perspective. And so when I referred back to this to Air is Human book, there was a quote by Sir Liam Donaldson, former medical officer of the UK, and he says, "To err is human, to cover up is unforgivable, and to fail to learn is inexcusable." And this was a presentation he did to the World Health Organization, and it's very pivotal to what we all do in hospitals, and the fact that learning from our mistakes, learning from our near misses, and trying to prevent these ever happening in the future. And so I thank you. It's not often I get to sit in a room in front of engineers, so.
So Catherine, how much time do we have for questions? 2 questions? Okay. Who's the lucky one? I know it was quite varied, but it's a lot about healthcare. No questions?
One
Okay.
in the middle there.
Oh, yes.
Now, I want to compliment Geoff for bringing those couple of slides, the handicap ramp, where you show the snowbank, and the cities are now doing a good job of addressing those issues. And the second one, where you have a toilet seat and it's not functional when the patient or the person comes from daycare, care facilities back to home. And I remember when I was retiring from the city of Ottawa, one of the inspectors told me, he says, "Ishwar, you want to take care of these volunteer stuff, here's a project for you. When you build a house, put a very wider entrance and a toilet that can be used by these kind of people." So I think the trend is there, except the developers have not picked on it. As you know, most of the developers like to put too many homes per square footage area. And I think engineers should get involved, and I'm endorsing what you're saying, picking up on that the engineering society should get involved and ask the building officials to change maybe mandatory code modifications and address the need of these senior people. One day we're going to get there ourselves. Thank you.
Thank you. You know, this is not rocket science. Sometimes it's just a question of, it doesn't require a bigger home or anything, it just requires a bit of thought. Architects, bless them, sometimes just like to see lots of horizontal lines on pictures, and that, you know, steps are not really necessary. You can engineer the surrounds so that you can approach a building on the level, and really just putting in a wider door, 2 inches wider if we got into that habit. We've now got some building standards in Ontario for accessibility. Unfortunately, the government didn't have the courage to apply them to residences yet, except multi-unit dwellings, but we'll get there eventually. But it's very interesting, the stairs issue. When you go downstairs, the big danger is you overstep a step. Going upstairs, you trip. It's not such a big deal. Obviously, the size of the step that you're landing on is important. It should be close to the length of your foot. There isn't much quantitative evidence for this. There's dozens and dozens of studies that have shown, as a sort of forensic studies of accidents and things, that it matters. But we have to generate the quantitative evidence, because if you think about it, increasing the run on a staircase has huge implications for cost. Massive, because every building is going to have to be that much bigger to take a lower gradient of step. On the other hand, not addressing this is costing us a fortune at the moment. So there's a lot of, I think engineers have a lot of responsibility that they can exercise simply by just using good judgment and trying to influence policy at the moment.
And I'd just like to add, my first job was because of Ralph Nader as a clinical engineer in Montreal. So thank you, Ralph, and thank you for Tim for bringing it up. And if you go to a hospital, ask if they have clinical engineers, because the Ottawa hospital got rid of them, but when they, long time ago, except for the Institute, and now I think Geo has one, but ask if there are clinical engineers, because I think your safety will be much better.
There's one fellow.
Oh, another question, Nick?
First of all, my name is Nick Monser. I'm from Sarnia, and you talk about stairs and all that sort of thing. It is amazing, the design of some of the stairs. Actually, the stairs into our police station in Sarnia are going to be replaced, but if you ever try to walk on those, I don't know how we ever got it through the system. But first of all, I want to congratulate you people on the work you're doing. The second thing is, when medical students are going through the process of being doing their studies, we should maybe have some engineering professors involved in talking to the doctors and giving them some advanced information like what you people have been talking about, so that the doctors realize that there is another side of the work that they have to do. Thank you.
Yes, I used to do that at McGill in Montreal when I was a clinical engineer for many years. Talk to them, talk to nurses, talk to surgeons, and we avoided a lot of problems that way. And I guess the secret of us being here today, Biomedical, to me it shouldn't be a secret, is that engineers working with doctors make better medicine.
Engineers working with nurses as well.
And
My
nurses.
professorship's in surgery, actually, and I'm not a surgeon. I was the first non-surgeon professor of surgery, and we in Toronto anyway. But we have 200 graduate students and postdoctoral fellows. Only a third of them are engineers and computer scientists. The rest are clinicians and a small section of health management. And I challenge you, even as an engineer, to move amongst those graduate students after they've been with us for a while, and you will not be able to tell the difference without being quite searching. because it is truly extraordinarily multidisciplinary. So there are nurses and therapists developing technologies, and there are engineers learning how to care for people, and everyone's learning how to run a business and stuff. So it's a new era of multidisciplinarity.
Okay.
I just have one comment.
Okay, sure.
The role of clinical engineering within the hospital is, part of that significantly is education and training. Providing training to nurses, for the most part, do a lot of the operating of the medical technologies. You'd be surprised to know that physicians, for the most part, really don't receive formal training on how to use a piece of equipment in the hospital. You've got these 40, we were talking earlier, they come in, and particularly residents who are these long hours and aren't given specific in-servicing on how to use devices. So, and I wholeheartedly agree with Geoff's comment. I was doing a speech with the engineering charity ball at University of Ottawa, and it was full of engineers, and I had to talk about all these different sort of specialties of engineering. And at the very end, I said, you hear all this stuff about clinicians and doctors and nurses, and said that it's in fact engineers that are going to save the healthcare industry for the most part. I got 2 sneers from 2 nurses who were in the room, but.
Great. Well, thank you very much. Our panel's going to be available, so Cliff, maybe you can pop up right after and just ask your question to the panel. That would be appreciated. Quick question for Nick, though. Did you spend a lot of time at the police station in Sarnia, Nick? Oh, okay. If you could please join me in thanking our panel. I think it was an outstanding presentation. Monique?